introduce Ellen. Ellen's in her 3rd year doing physio up in Edinburgh, so very, very close to finishing now, Ellen. Throughout the course, she tells us that she's had placements in acute stroke, MSK, pulmonary rehab, but regardless of what placement she's had, she's found that pain tends to be a common problem experienced by lots of patients. So Ellen's presentation is going to look at the use of pain neuroscience education as a potential intervention for chronic pain, specifically in relation to fear avoidance. And education is recognised as beneficial to chronic pain populations, as most of us know, but can sometimes lack robust evidence. So, and there's a growing interest in pain neuroscience education, specifically as part of a biopsychosocial approach. So Ellen's going to present the existing evidence around this, discuss the benefits it can offer, and how this can relate to reducing fear avoidance and pain-related disability in chronic pain populations. So I'll just hand over to Ellen, and I'll put myself on mute.
Okay, I'll just try and share these slides again. Hopefully they work. Perfect. Okay. Yeah, firstly, I'd like to say thank you so much for having me to talk today. It's been a really good opportunity to kind of look into an area of chronic pain I think that we don't cover in as much detail as maybe we should in uni. So my presentation today is looking at pain neuroscience education specifically for fear avoidance in chronic pain populations. So to begin with, what is pain? So the International Association for the Study of Pain has described it as an unpleasant sensory and emotional experience that can be associated with actual or potential tissue damage. So essentially, it's a reaction to danger signals that the body receives from sensors, and these can be mechanical, temperature, or chemical related. However, it is also highly subjective, so it's influenced by people's emotions, past experiences they may have had as well. And it is an extremely useful adaptive response that's been developed to protect the body and promote healing in the acute sense. However, chronic pain is when the pain persists past that normal tissue healing time of 3 months. And the increased sensitivity of the nervous system then leads to these longer lasting changes I'm sure you're all aware of. So things like hyperalgesia and allodynia and areas unrelated to the actual original site of damage becoming involved. And then this repeated stimulation causes these to become more permanent, and people continue to feel this pain despite the fact that the initial injury may have healed as well. And then thinking about the biopsychosocial side to it, these are some of the risk factors for people to develop chronic pain. I think it's quite important to note that a lot of these are not necessarily physical factors. So although we've got clinical factors like whether someone's had acute pain in the past or multiple health conditions, a lot of it's to do with their socioeconomic background and the attitudes and beliefs that they have. And quite often as well, that people may have more passive coping strategies. And for example, they're very reliant on their medication to manage their pain. And often people can have very low pain self-efficacy. Taking this more to fear avoidance, self-efficacy has been shown to act as a mediator between people experiencing pain and subsequent disability. So this can lead to them having unhelpful beliefs and then developing more maladaptive behaviours as a response to this. So these can be things like worrying about things that may cause them pain, whether or not this has actually happened, and then a misconception that the pain is causing them further damage as well. And if people think that when they're in pain, they're causing further damage, then they'll avoid movement, they'll become hypervigilant. And this then leads to a downward spiral of reduced activity, lowered mood, and an increase in disability and a lack of activity. And then the result is a significantly reduced quality of life for these people. This can be described quite nicely by Vline's fear avoidance model of pain. So here on the left, it shows that people catastrophizing about their pain makes it worse, and they get into this negative spiral, avoiding movement and not doing the things that they enjoy. Whereas if they're able to confront the things that are feeding into their pain, so these emotional factors, these negative beliefs and attitudes they have, and actually confront these, then this can lead to a much more effective recovery from the pain that they're feeling. So it's important to support people to try and avoid this negative spiral through education. It's also important to be able to measure this fear avoidance that people have, so it actually can be a useful kind of tool in rehabilitation. This previously has been done using these scales here, which you may be, I guess, familiar with, but neither have related pain and fear avoidance together specifically. More recently, the fear avoidance component scale has been developed to do so. And this has clinically relevant levels to support the assessment and treatment of fear avoidance. And then again, these can be used as important outcome measures for people as well. Quite often, if people have something they can see that they've improved from, so they're like building blocks for them, that can help as well. But previous treatments for chronic pain have often been quite passive and focused on physical structures linking pain to a pathology. However, this has been found to have small effect sizes for treatment, neglects what we now know to be very important aspects of chronic pain, so people's understanding of their pain and their pain cognition, essentially. And this biomedical approach is now kind of fairly outdated, and a more biopsychosocial approach is far more appropriate, considering all the different factors that people can have feeding into their pain. So whether it's their kind of stress levels, emotional experiences they've had, what they're feeling at the moment, and any past experiences or conditions too. The current guidelines for chronic pain recommend a multimodal approach to management, and this kind of person-centered approach can improve the chance of successful outcomes. And here's a list of some of the current accepted interventions for chronic pain. Things, although involving psychological intervention, physical therapy, but also pharmacology as well. So looking more specifically at pain neuroscience education, this falls under the education bracket. It's a cognition-based education intervention. It's been very important for people who are experiencing this pain fear cycle and are very fear avoidant either in their beliefs or their behaviours. And it focuses on the neurophysiology and the neurobiology of pain along with these people's own contextual factors. So the aim is by explaining how their pain works, this helps them view it as less threatening and they can then effectively manage it better. So it differs again from previous biomedical approaches, such as the back school approach, which links pain to a pathology and doesn't address the psychosocial aspects. But it also it's got some differences from other psychological therapies that are used for chronic pain. Things like cognitive behavioural therapy, which focuses on emotions, and motivational interviewing, which encourages people to change their behaviours, which both are widely accepted as well. So there's a lot of potential there for PNE to be used alongside these to have an effect for people as well. And the whole principle of PNE was based off Moseley's explaining pain principle, which was first described in 2002. I'm sure you're all aware of Moseley and some of his work. He then looked further at the neurophysiology component of education in 2004, basing this off Wallen-Melzak's textbook of pain. And this has then led to the development of pain neuroscience education as a more structured intervention. And they've also written the book Explain Pain, which this image on the side here is taken from. And this is a resource that uses metaphors and images to support both clinicians and patients when they're managing pain. The content of these sessions tends to include things like nociception, nociceptive pathways, looks at central sensitization and neuroplasticity. However, there's no reference to anatomic models, but also little discussion of emotions and behaviours. It's very much focused on the pain mechanisms themselves within the central nervous system. It uses metaphors to try and help people, so referring to their pain as an overactive alarm system, or like a smoke detector that's kind of gone into overdrive, and things like this can help patients understand their pain and think about it in a different way. A common misconception they may have is that going through their pathway and being treated for their pain is that people are telling them it's in their head. They're saying, well, there's no tissue damage, your pain's not there. And it's, I think, really important to reassure them that you do believe them. Their pain is a physical thing. It's very much real within their nervous system, and these signals are going to and from their brain, even though it doesn't link up to what tissue damage they may or may not have. So helping them to understand this can help them feel believed and begin to actually manage and treat their pain more effectively. So in this sense, PNE's benefits address the kind of the inaccurate knowledge that people have of their pain and help to improve understanding. So it's strongly linked to fear avoidance and is very, very effective for these people exhibiting fear avoidance and maladaptive behaviours and avoiding movement and activity. And targeting these beliefs can then have knock-on effects to influence behaviours. However, PNE doesn't directly focus on pain reduction as its main goal. This can happen as a result of increased participation in other influencing activities, things like improvements in physical activity and exercise, which is known to then have a knock-on effect on pain. But the main focus is people's quality of life and helping them to participate more in things that they enjoy doing. Reductions in disability have also been found by a variety of studies to be more significant as you look at it over a longer term, which suggests that people take time to develop these changes, first their beliefs and their behaviours. And as their management of pain improves, they then get into a more positive cycle of better participation with more meaningful activities, more improved pain management, and then more successful engagement after that. And then they also have more acceptance of active treatments to help the recovery, rather than maybe an initial passive approach where they expect that their pain is something that can just be fixed. PNE alone, there's varied evidence to support whether this is clinically significant for pain-related disability. However, it does have improvements to people's knowledge and understanding, and all of this is beneficial for someone who is fear avoidant. And it wasn't initially intended as a standalone treatment and can have a significant impact for people when it's combined with other interventions. Things like, for example, cognition-targeted motor control training. So this involves using exercises to retrain learned unhelpful movements. So if people are very fear avoidant of, like, for example, bending forwards, if that causes them back pain, it's finding ways to retrain this so that they're able to do movements that they think will cause them pain without being in fear. And these are communicated in a way that lines up with their PNE sessions, linking the two together. And these exercises get gradually more difficult as they move towards things they're more scared of doing. And this has been found to be more effective than just traditional kind of education and exercise. Also combining it with psychological interventions like motivational interviewing. These can be quite a nice complementary combined way to work with people. The PNE focuses on the pain mechanisms, and then the motivational interviewing supports behaviour pain change strategies that can follow. And combining it with traditional physiotherapy can also be effective at reducing pain and pain-related disability. So can CBT and physiotherapy, and it's unknown whether PNE or CBT is more effective. So this is a potential area from further research to see what the most effective way to help people with their pain is. And this is in line with best practice guidance for chronic pain. This also can indicate an important role for physios as a profession with a knowledge of neurophysiology and a movement-based approach to interventions. We're really well placed to help people in this situation. So delivering PNE, the effective delivery of this is important. However, some studies have found that it's not as effective if the material is written down and presented to people. It's more effective when delivered face-to-face in a session. Although some studies also found that using a metaphor-based book such as Explain Pain can be useful for improving catastrophizing and can effectively come before active rehab. So this suggests that how the material is presented is important. People are more likely to want to read a book with pictures and metaphors that's a bit more creatively worded than a book that just says, you should do this, this is good for you, just providing advice. And this is a suggested way of presenting this, so having a combination of education, a booklet that explains things, follow-up sessions, and then more active management. And this can be done also in group or individual delivery formats. Also important to consider how ready someone is to receive the information they have. It can be very, very difficult for people to accept that they have chronic pain and that it's not what they initially thought it was. And also then changing their beliefs or behaviours can be very, very difficult if people have got very ingrained in one way of acting. Trying to break out of a negative cycle they have can be very difficult for people. This can be described by the trans-theoretical model of behaviour change, which again, I'm sure everyone's familiar with. And different people in different stages will have different interventions that work for them. So this model, this image just shows it here, and one area that can be particularly useful for PNE could be someone in the pre-contemplation stage, where they view their pain as a problem that can be fixed medically or with painkillers, and they've got no intention of changing their behaviours and their thought processes to help themselves. So PNE can explain to them and help them understand where their pain comes from, why they're in pain, and then start to look at changing the beliefs first rather than jumping straight in with more active management strategies. And then they can work their way up the stages of the model. So there's already clear links in the literature. There's been a lot of research into chronic pain, fear avoidance, and pain-related disability as a result. And more evidence is emerging to support the use of PNE to help people with their pain. Some areas that could be useful for future research are the most effective ways of delivering PNE. So there's currently little evidence to support individual versus group approaches, or incorporating a blended approach, particularly after COVID. Everyone's got more used to using online methods of treatment, so this could be useful for time cost effectiveness. If people are in a lot of pain and they're not always wanting to come in to see you, this could also be an easier way for them to manage that if they were happy to. And determining long-term effectiveness and how well benefits of PNE are retained, and then comparing it combined with other things like motivational interviewing, CBT, to see the best optimal intervention that you can use. And then integrating this into the current guidelines as they change and are updated. So in conclusion, chronic pain is an incredibly complex and widespread condition that significantly impacts people across the lifespan, and is influenced by a huge range of factors, not just physical, and this can lead to a downward spiral of pain that they get into, negatively impact people's rehab. So by targeting the fear avoidance that people may have when they're in pain, through PNE, explaining these pain mechanisms, you can help break people out of a negative cycle. And further research is needed to determine the most effective way to do this. But it does have a successful intervention to approach chronic pain management. I think it's incredibly important to support people in educating them about their pain and giving them that power to help themselves with their own health. There's only like a limited amount of time that you can see someone and in a face-to-face session or in whatever session you have, but if you can help them to understand their own condition, then they can use that to help themselves improve throughout the rest of their life. And that's a really powerful thing I think that PNE can do for people. So very much for listening, and open to any questions.
Thank you so much, Ellen.